we're super excited to kick off our final morning. So hopefully everyone has had an amazing brunch. Yes. Thank you to the team for facilitating all of that. And that bread pudding, oh my gosh. Yes. So we are super excited to round out the symposium with our last group of sessions, or session. We're going to be kicking off session C with a talk by Malaika Simmons on addressing SDOH with human-centered design. How's everybody this morning? Good? Good morning. Good morning. Good morning. Good morning. Yay! Okay, I know it's not Sunday, but it's such a pleasure to be here with you all. This is only my second time in Chicago, and I apparently only come when I'm coming for a symposium, so okay. Love being here with you all. The fellows and the data and the research is just fantastic, and I love every moment of it. So we're going to get started, and we're going to talk about design for health equity. First, some of you were here last year, so we've met, but if you've not met, my name is Malaika, as in I like Malaika, and I'm the founder of Momentology Media. We're a boutique consultancy specializing in empathy-based leadership, executive coaching, and workshop facilitation. I'm also the COO of the National Accelerator for Discovery in Precision Health, ESS a long name, to say APH. And I'm a doctoral researcher. So my PhD is in international psychology. My specialization is in organization and systems. So I've done quite a bit of work on the continent, so I absolutely loved hearing all about South Africa yesterday. I was there last year. Fantastic work. And my career has spanned over 20 years in health, design, psychology, and systems change. I'm looking at my screen. Thank you, sir. I think I was like, I don't see what I see. So I call everybody world changers because I really do believe that each of us has the power and the ability to change the world in some small way, or even big ways, but it's just a matter of us sharing light with one another. So I'm a world changer. I'm a facilitator of discovery. I come from a family of teachers. I cannot help myself. This is a family business. So I love to help other people see things that they couldn't see the day before, and I'm an avid researcher. I was a kid walking around with a dictionary and a thesaurus at like 6. So I've always loved words and looking into things, and I'm basically a humanist. I believe in the power of people, and I think that together we can make solutions with the people who we are solving for. So one quick fact about me, fun fact, I can say thank you in 58, thanks Jacob, 58 languages. Gratitude is my absolute favorite emotion, so every time I run across someone who speaks a different language, I learn how to at least say thank you, and sometimes food, because food is really important. So social determinants of health. So I'm sure you all know what social determinants of health are, but I'm just going to go over it briefly. There are many factors or drivers of health, and they're sort of 5-ish, and I'll talk about the one that's involved in a second, but housing and neighborhood conditions, food access and nutrition, transportation and mobility, education and workforce opportunities, and social support and community context. Social support and community context is listed last year. It's not in any particular order, but I personally think that social support and community context does not get enough attention because you can have a job and you can maybe get to where you're trying to go to, but there's too many of us that live in support deserts, right, where we don't have the type of support that we need to function on a daily basis. I also teach and tutor in executive functioning. And it starts when we're really young, but the young people who are dysregulated and don't know how to manage themselves become adults that you have to share a project with, right, at work. So this is really important throughout our lives. The last one is digital equity and access to information, because what I have found is, again, all these things are intersectional, of course, but when we don't have the access to digital technologies and innovation, all of these other things, it's not that they don't matter, but they matter a little bit less. So why design thinking? So design thinking and human-centered design are coupled and not exactly the same thing. Design thinking is an approach and a way of doing things. So it's structured creativity to solve complex human problems, and it starts with empathy. And I've had this conversation with a few of you over the last couple of days. People often misunderstand empathy. Empathy is not sympathy, right? It is so very hard for humans to work together when they see things differently. And of course, in where we live in the country and what's going on, I'm sure all of you can understand how it's very difficult to have conversations with people you don't think the way that you do. The problem with that is that sympathy is I feel sorry for you. Empathy is I feel as you do. And while that sounds good to a certain point, it becomes troublesome because, for example, I'll use an example we talked about yesterday, Hannibal. Any of you seen Silence of the Lambs? Yeah? So there's a TV show, Hannibal, that's based on Silence of the Lambs. I love that TV show. And it's not necessarily like dinner conversation, right? And some people can't understand, like, how can you love that show? He's a serial killer. First of all, I'm a psychologist, so I'm in the territory. But the understanding of, I can understand why he thinks a way without me thinking the same way. And so once we understand that empathy does not mean that you feel the exact same as someone does, it means you can see through their lens. So it's just like if you take somebody's glasses and put them on and you can see with their lens, don't do that, y'all, because it's factory eyes. But like if you do that, you see through their lens. That's all empathy is. Empathy is a lens that helps you to see how others see so that you can solve in a way that suits them. And that's what human-centered design is about. So there are stages. You empathize first. Okay, let me understand. Empathy is synonymous with understanding. Let me understand what you're going through. You define what the problem is from that person's landscape. You ideate, you create some ideas about how we might tackle a particular thing, and that's where we get to the how might we. We're Dr. Chen. How might we, right? That's how we get to the how might we's, and then we prototype. Okay, now that we have an idea, let's make something of it, right? And then we have to test it. Let's put it out there into the wild and see what happens. So when you start to do this, you shift from designing for communities to designing with them. These things should be co-created with the communities that you're trying to solve for. And that's where the Jedi had to be careful not to get in any trademark copyright trouble, y'all, but y'all know what Jedi is. Okay. So it's the journey, it's the experience, the desired outcomes, and the impact that you're looking to achieve. And so if you keep that in mind as you're developing your research projects, what's the journey of the people who you're serving for? What experiences do they have? What are their lived experiences? And what outcomes, what are the desired outcomes that they want? Because I know we get sponsors and money from folks and funding, and I have a secret, don't tell nobody, the funders don't know everything. I'm just saying. So we actually need to have actual conversations with actual people. I'm going to give you a use case. So food is medicine. So some of you, I've seen a lot of food instability research in the last couple of days. So food is medicine. If say you're putting together a food is medicine program and your goal is to improve nutrition access, and one of our presenters did a fantastic job of talking about the different types of access that there are, right? So you want to improve nutrition access. The community has revealed that transportation was the bigger barrier. So you thought it was maybe that local grocery stores aren't open long enough for people to get the food that they need. But when you actually go to the community and talk to people, they're like, yeah, no, it's way over there, and there's only one bus, right? So whatever the challenge may be. So the solution may be to add vouchers for produce distribution. So we can be lobbying. There's a lot of politicalness that goes into the advocacy that we do, right? So Blue Cross Blue Shield or Aetna or whomever, they have the power to do whatever they want with their benefits, right? So why can't they add a transit voucher to their benefits? I worked with one provider who built a playground. And they're like, why is a HMO building a playground? Well, they built the playground because the majority of their members were mental health, there's a mental health program. They weren't coming to their appointments because they didn't have any place to put their kids. Build a playground, get staffed up, problem solved. People start showing up to their appointments. So stop making assumptions about what we think people need or are doing and actually asking the question. So it results in higher participation and improved nutrition outcomes. So if you decided that you had your little plate, the triangle, and how many foods, that's great, but can people get to it? Can people access it? I always say, people say, if feed a man a fish? No, give a man a fish, you feed him for a day. Feed a man a fish, you teach him how to fish, and the point is, my first thing is, I say, well, I'm a vegetarian. So that doesn't work for me. And the reason I say that is not to be contrary, because I do kind of like being contrary, but it's also to point out that how about teach a person to eat? The whole point is, how might we get better nutrition? So stop pre-solutioning, right? Oh, we're going to teach these people how to fish. Maybe they don't eat fish. Like, that's the thing. And your result is higher participation because people know that you see them, and then they'll participate a little bit more. Data and engagement. So the traditional sources of data, specifically in the health equity field, are the EHRs, there could be surveys, census data. Human-centered sources are storytelling, and we've heard a lot about that the last 2 days in journey mapping. Asset mapping is one of my favorites, and we've talked about the difference between asset-based reporting and deficit-based reporting. Really, really important. We have to stop going into people's communities and telling them what's wrong with them. Like, they know that they have problems in their communities, and they probably, we had our conversation at our table, they probably already have the solution, but guess what they don't have? Money. Right? So let's stop trying to recreate the wheel inside of communities and start asking and start bringing the resources that they actually need. But by asset mapping, we say, oh, you know what, you do have this and you have that, and let's link them together, versus creating a whole new thing that goes down rabbit hole. And the last part is it's a blend of quantitative and lived experience. So I always say that lived experience is empirical evidence, right? We often, and I admit my bias because I'm a qualitative researcher, so I love the why, but we do need the what. We do need the how many. But when you say how many, you also got to say, why is it? Oh, 5,000 people catch the bus. Great, that's a number, that's a data point. It went down to 3,000 people, and down to 1,000 people. I guess we'll cancel the bus service. Are you going to ask why people stop taking the bus? Right? So if you're not asking the qualitative part, you're missing out. So the data and the engagement go together. They're not opposite ends of the spectrum. This is my favorite guy. If you guys were here last year, you remember. So we're going to do a really, really quick exercise. This is my little empathy man. In your notebooks, if you have them in front of you. If you're not an artist, don't worry about it. We're going to draw a little empathy man. And I'm going to draw one really quickly here and put it up so you can see. And we're going to kind of talk through really briefly what it means to bring empathy into health equity work. And you will see that you don't have to be an artist at all. One of the other things that I do is called persona development, right? And so if you all are familiar with personas, it's basically an idealistic vision of whoever your audience or your users are. As a matter of fact, on the first day, Shabam showed you 4 of the personas that oh, sorry. On the first day, Shabam showed you the personas that we're using in the project. So, if everyone can see this is just your empathy person. So for every community that you are solving for, you need to think about what are they thinking, what are they saying, what are they feeling, and what are they doing. And so if you would just write on your paper when you draw this, either at the bottom where you want, who's your community person, who's your project solving for, and keep that as a sort of quasi persona for yourself. How do we know what they're thinking? Well, we ask them. We can do that through surveys. How do we know what they're saying? Well, we actually have to go to the communities and speak with them. And then how do they feel and what are they doing? We know what we can start to figure out how they're feeling by what they're doing. We watch behaviors. Margaret Mead, a famous anthropologist, says what people say, what people do, and what people say they do are 3 different things. And so we have to be paying attention to all of them. And why human-centered design? It is the bridge between data and lived experience. It translates insights into actionable strategies, and it builds trust with communities, which leads to higher engagement. And it matters because higher participation in research programs is really important. And it improves patient satisfaction and engagement. It creates workforce pathways for underserved groups. And the workforce pathways, I think, is really important because I believe it was Beth, when she was talking about her program. These programs that we're creating, these things we're doing, are actually making jobs for people, right? They're making jobs for people who are already doing the work. So they're giving them the ability to solve for their own people, and that's really, really important. And there's lots of opportunities in AI and technology for equity, public-private partnerships to scale solutions, and training health leaders in creativity and empathy. You can all guess that the last one is my favorite. Training health leaders for creativity and empathy. We can do this. Think of who you're solving for. Think as they do. You don't have to be them to think like them. And listen to them. It's really a matter of opening your ears and listening and hearing and being willing to do the things that may be uncomfortable or may seem like it's weird for you to do that. Well, guess what? You're not the population that needs the service. And it's kind of messy, right? This stuff is not easy. There are facilitators like AI and technology and the partnerships we talked about and training the health leaders. Yes, that's great, but there are barriers. Politicization of health equity, and we all know everything is very polarized and political nowadays, but there's big policy and there's little policy, right? So you don't have to enact change in Congress. Good luck with that. You don't have to enact change in Congress to make changes. You have local politics that you need to get involved in. You have advocacy. That's why they call it grassroots from the bottom up, right? There are school boards. There are places where you might not think because you're a health-related project that it would be welcome, but they are, right? So go to your libraries, go to your school boards, go to your local councils. You can start to enact change at the local level. And there's funding pressures, and I don't even have to talk about that. We all know there's short-term and long-term, right? There's some that's immediate. You're about to lose it. You're coming up on the end of the grant. What do you do? I will say really quickly about that, that it is more important than ever to work with communities in those, the tighter the pressures for funding, the more you need to work with communities. Because they cannot think that you only show up when it's time for a project. If the first time they see you and the last time they see you is wrapped around a project, they're gonna stop answering the door. And they're rightfully so, right? Communities are over-extracted. They're tired of being the go-to to only take from them. So it should be reciprocal. It should be, there's something you should be giving to them before you even ask them for anything. And then ensuring authentic, not tokenized community participation. Please don't go and go 1, 2, 3, you come with me in the community. Like they see through that and they've been through that. And so I know a lot of us are well-intentioned and we have all these things and deadlines on our plate, but we are dealing with people, and so we should act accordingly. Lastly, again, lead with empathy, listen to what the community say they need, not what you want to do. Think like a designer, ideate and test small bits and pieces, right? And then balance data with dignity. This is one of my favorite. Numbers and human voices need to be voiced at the same time, need to be surfaced. And lastly, I'll end with a reflection question. If you could redesign one healthcare process to align with community needs, what would it be? And remember the Jedi. Remember their journey, their experience, what are the desired outcomes and the impact. And I think we'll all do a lot better in the research field. And thank you. And if you all, everybody always has their phones. I would love for you to scan the QR code, just let me know how I did, and if you have any recommendations. I love doing this work for you all, but so like you all, please everybody answers. So please, thank you. Any questions?
We have time for one quick question.
It's not a question. It's, oh my God, did this resonate with me? Because I went home from yesterday, went to my daughter's dive meet, and then had gotten an emails for these performance measures, the evaluation that I sent to Minnesota that are due next week. And the program officer at IDPH sent all these questions. I'm like, we finalized this. So she came back to me and she goes, she's worried about the performance measure numbers. And these whole grants are all about incorporating SDOH. And as I'm listening to you, I'm like, she's thinking, okay, we need to get more clinics, we need to get more patients, so we need to be tracking more, so I need to be increasing over the next 3 years. And I said, no, that's not what we're trying to do. We're trying to increase control. So you've created these buckets of this clinic needs to work on pharmacy, this clinic needs to work on oral health to increase hypertension control. And I had a light bulb moment last night where I said, no, what you need to be doing, because all these clinics don't have funding, you need to go to them and say, what is it that you want to try to do? Because we know they all want to increase the outcomes for their patients and get better control of their hypertension. So what is it that you want to try that you can implement in your clinic next week? And I for an hour and a half, I was on a Zoom with her before coming in here, discussing, like, talking her through that. So this, you just put into the words around what I was saying. I've already got it planned that we're gonna have you talk to all of IDPH.
The last thing that you were saying, the last thing I'll say is, can we kind of get rid of the word compliance? It does not resonate in communities. How about alignment? How about getting them aligned to their health goals? Compliance sounds like we're in charge and they aren't. So sorry for the last thing.
Thank you so much. Okay, all right. And we might have to keep our guy up here. That's okay. Oh, that's Ethan. Yeah.
Oh, keep the guy? Oh, yeah, we keep the guy. He's so good. He's so good.
All right, next up, we're going to hear from McKenna Magoffin. Am I saying that correctly? On quantifying SDOH risks of syncytial diseases. Hello, everyone. Is the mic working? Yes. Okay. Well, I think we're going to begin. Thank you so much for having me. My name is McKenna Magoffin, and I'm a data scientist. Today, I'll be presenting on behalf of Social Determinants on our work on the predictability of SDOH factors on health outcomes. Okay. First, I want to introduce our company. Our company is Social Determinants, and we're an analytics company. Our mission is to use SDOH at scale to improve health across the U.S. We have been incorporated since 2017, and we serve healthcare payers, life science companies, community nonprofits, and what we do is we we build individual and community SDOH risk score and social measures, and we give that information to our customers who can do interventions and improve their member health. At Socially Determined, we believe in the connection between SDOH and health outcomes, as I think everyone else does in this room, but we want to establish that in a measurable way. So to understand that relationship, we wanted to look at the predictive power of our SDOH measures against population health outcomes. For this project, we partnered with Virginia Tech, specifically their computational modeling and data analytics capstone program, which is CMDA. This program takes students and for a semester introduces them to an industry problem to solve. And in the spring of this year, we engaged students in a industry problem in the field of SDOH. With our guidance, we asked students to apply our SDOH risk metrics on the CDC Places dataset health outcomes to look for predictive power. We gave our students our community analytics package, and this package centers around 7 SDOH risk scores that we've developed at the community level. And those risk scores are economic climate, food landscape, housing environment, transportation network, health literacy, digital landscape, and social connectedness. And alongside these risk scores, we have related engineering features like estimated SNAP households that are related or supporting the risk scores. We built these risk scores at the hexagon level. They're a geographic resolution that tessellates across the US, and they have a diameter of 200 to 400 meters depending on the urbanness, or how urban an area is. This dataset takes 17 data sources, which ends up being 500 data points as inputs into the data we develop. And for this study, we took our hexagon resolution data and used population-related averages to aggregate up to the zip code level to align with the CDC Places dataset. And I think we're all probably pretty familiar with the CDC Places dataset, but just in case you aren't, it was first available as the 500 Cities Project in 2016 and was available as what it is today in 2020, and they provide health and health-related data, but for us, we focused on health outcomes. And they provide the data at the county, the places, zip code, and tract levels. But for us, we focused on the zip code. Today, we're presenting our results on predictive power of our SDOH risk measures on 4 health outcomes: diabetes, stroke, obesity, and depression. And we chose these, or we chose to present on these today because of the high predictability we saw, but also because they have high impact on our communities. For diabetes, more than 10% of the US has diabetes, and more than 1 million people are diagnosed every year. For obesity, nearly 1 in 3 adults is overweight, and obesity is a comorbidity, so it increases the risk of hypertension, type 2 diabetes, coronary heart disease, and stroke. And in 2022, stroke was the cause of 1 in 6 cardiovascular deaths and is the leading cause of adult disability in the US. For depression, more than 20 million Americans have experienced a depressive episode, and that co-occurs with other diseases like cancer, stroke, and heart attacks. For our project setup, we needed to clean and adjust the data, so we took out highly correlated features, features that had high null rates, also pulled categorical features into numerical ones for our modeling. And in the study, we ended up looking at nearly 32,000 zip codes. We ended up using 97 of our SDOH risk score and social measures. And once we had done our predictions, we looked at the impactful features using a SHAP plot. If you're not familiar with SHAP values or SHAP plots, just a brief explanation. A SHAP value has direction and magnitude, and it's model agnostic. So it's a great way to look at how much impact a feature has and what direction that feature has impact. So on the example that's right here, you'll see that the color bar tells you the value of the feature or the input. And then if we look at the first one, for example, you can see that when there are higher values for very poor health literacy, there's a higher impact, and we are predicting a higher prevalence of the target. We looked at 3 models to look at predictive power, and we actually saw a signal in all 3. But today we're focusing on XGBoost, a gradient boosting decision tree algorithm. Let's get into results. We're talking about diabetes first. We saw an R-squared value of 77%, and that's visualized on the left here. But what I really want to talk about is the impactful features. We saw health literacy as very impactful. And this is the graph we just saw actually, but we saw that when there's a larger population with very poor health literacy, we predicted a higher prevalence of diabetes. We also saw social connectedness and social connectedness related features. So we have this social interactions index, which is similar to the social infrastructure that someone talked about yesterday, but just the ability to interact and build those social interactions based on the infrastructure and the resources available in the community. Mental health barriers index, which has to do with the capacity of the community to support its own mental health. And then the social connectedness score itself are all impactful for diabetes. And we can see, if we look at the bottom feature, the very poor social connectedness, when there's a larger population with very poor social connectedness, we're again predicting higher diabetes prevalence. The last impactful feature I want to focus on this slide is estimated SNAP eligible households. We saw here when there were more SNAP eligible households in a community in a zip code, we predicted a higher prevalence of diabetes. Moving on to obesity, we also saw an R-squared of 77%. And when we looked at the impactful features, there were similar ones to what we saw before. There's health literacy, there's social interactions index, and we're also seeing new ones, like we're seeing education as important. When there is a larger population with an advanced degree or a degree above an undergraduate degree, we see a lower prevalence of obesity predicted. Also here, we see that the most impactful feature was actually median housing cost as a percent of income. And when that median housing cost is higher, we're predicting a lower prevalence of obesity. Also here, the last thing I want to point out is median food budget as an impactful feature. When that food budget is higher, we're predicting a higher prevalence of obesity. For stroke, we saw an R-squared value of 76%. Here we have some familiar faces, health literacy, again important, and social interactions index with the same directionality that we saw before. Also here, there are some housing environment related features. We see rooms per person, rented households, and when there's fewer rooms per person, we see a lower prevalence of stroke predicted, and when there's more rented households, we're also seeing a lower prevalence of stroke predicted. Our most impactful feature here ended up being estimated SNAP eligible households, which we again have seen before. And there we saw, again, when there are more eligible, SNAP eligible households, we predicted a higher prevalence of stroke. Finally, I wanted to discuss depression. Depression, we saw an R-squared value of 57%, which is lower than the previous, but still significant. Here we see health literacy and education, but we saw the opposite directionality that we saw before. If we look at when there's a larger population with very poor health literacy, we saw a lower prevalence of depression predicted. And for education, which we also saw in the obesity model, we saw when there's a larger population with a college degree, we saw a lower prevalence of depression predicted. Also here is the housing environment score and related housing features, old households, and median housing cost as a percent of income. And we saw, again, maybe the opposite relationship that we would expect, but when there's a larger population with a very good housing environment risk score, we saw this makes sense, but for this one, we saw when it was larger, that we have a lower prevalence of depression predicted. To conclude, our models, our models had strong predictive power. Particularly, we saw themes in which features showed up across the models. We saw health literacy, housing environment, social connectedness, and education often show up as impactful features. The big takeaway from this study for us is that the models were able to have predictive power even without clinical health data. We're able to look at these health outcomes and use SDOH and show that predictive power. For this project, we had some limitations. Our predictive power does rely on the CDC place's data accuracy. So this data is based off of the BRFSS, which is survey data, and that data is modeled, and they also use American Survey data as well. We also had a limited time engagement for the analysis. We worked with the students over the semester in the spring. And also the data was predicted at the zip code level. And this resolution, we were talking about parcels yesterday, but this resolution isn't socially homogeneous. So leading into my next steps, what we'd really like to do is partner with our clients to get actual individual clinical data, clinical health data, and aggregate that to a socially homogeneous resolution. Particularly, we're interested in the block group level. And in general, we would love to extend the research and do a follow-up with the CMDA capstone program. To close out, I just wanted to say we're really excited to work with Virginia Tech, and we really appreciate their contributions, and we're excited to work with them again, hopefully. And I want to acknowledge the 3 students that worked on this project. Casey, Abrar, and Ananya. They're all very passionate, they're all great to work with, and we're really excited to see what they do next. With that, I'd like to open up to questions. Yes? Exactly.
Hi, McKenna. Thank you very much for that interesting presentation. I think you spoke about in 1 or 2 slides before that.
Yeah.
Yeah, that one. So I'm curious about those 4 factors which were consistent across the 4 outcomes that you explored. Which ones do you think are protective and which ones are risk factors? Could you talk about that?
Which ones are predictive or?
Yeah, so like which, yeah.
Protective.
Some factors could be protective, like if we increase maybe education, then obesity goes down. Some factors could be.
I see what you're saying. Okay, yeah. Yeah, so I think we saw that, let's get together really quick. I think that, if I'm thinking about this right, that definitely social connectedness would be protective, right? And hopefully I'm answering this correctly. Definitely, mostly the thinking about predictive, but yeah, so for directionality, we saw that for social connectedness, when there was a larger percent of the population that had poor social connectedness, we saw a higher prevalence of the disease predicted generally with the 4 that we looked at. So I would expect, improving the social connectedness in an area would be protective. And that's exactly what we work with our customers on is the intervention part of this, and trying to minimize the prevalence of these diseases and other goals. And I think, and I hope I'm understanding you correctly, that education, housing programs, health literacy will be assuage
I can talk to you after.
Yeah, that would be great, thank you.
So thinking about like social connectedness in a community that's under-resourced, people, if they can, are gonna try to get to that community where it has the higher housing stability.
Mm-hmm.
And so when you get to the higher housing stability, you have more connectedness. So I guess I'm thinking, do you control then for communities that you know are more transient or that are because if they're under-resourced for employment or if they're working multiple jobs, does that affect connectedness? I'm just trying to think, the other thing was I think you showed that for depression, a lower health literacy predicted that they would be lower depression.
Right.
And so in that case, then does education create more anxiety, which creates more depression? And so,
Ignorance is bliss.
yeah. So are there other factors?
Yeah.
Do we need a three-way box that's looking at these factors?
Yeah, I think definitely we want to think more about interpretation rather than just predictive power in next steps. I think that's really what I would think our focus would be, because it is interesting to see these opposite relationships than what we'd expect, and SDOH's relationship with health is so complex that I think taking a look at it not just with predictive power as the focus is really what we want to do next.
All right, one more quick question, and I know there's a bunch more, but we'll have to wait for the last kind of break before the end of the day.
Hey there, this will be really quick. First of all, thank you so much for the overview, fantastic. How do you define health literacy, and are there gradients to health literacy, and how do you measure it?
Yeah, so health literacy is based on a lot of different things. One of the first things I think about is, education, and thinking about, there's a whole brain here, but education, culture, different things that would give you barriers to understanding the health, or the resources you're being provided. So one of the first things I think about is language. If you have a language barrier, health literacy is going to be harder for you. And if you have a lower education, then maybe you're not understanding as much from what you're being told for prescriptions or different instructions that you get. So that's what we're thinking when we think health literacy.
So potentially some of their education is showing up more than once in that top list.
Yeah.
I think that's kind of where she was going to that as a measure.
Yeah.
Thank you so much. This was awesome. Thank you. And as that reviewer number 2, if you are ever publishing with CDC Places data, remember that because a lot of they use SDOH to model the data, you have to be really careful with the interpretations and that sort of thing. But for associations and there's always something you can note, but it is how it is.
Yeah.
Awesome. With our final talk, mapping vulnerability to climate disasters, we're going to bring it back to, you know, the big picture and with climate. So Alicia, if you can tell us your last name.
Yeah, it's
Okay.
Thanks. Hi, I'm Alicia, and I'm sure my last name will pop up, and it looks really long and confusing, but it's Alicia Adiwidjaja. Yeah, so today we're talking about fire, and more specifically the January 2025 wildfires and their impact on Children's Hospital Los Angeles. I did the boat tour that everyone says to do, and they talked so much about the Chicago fire. They're like, this area burned down, and then that area burned down, and I was like, can I talk about fire in Chicago? Is that allowed? But then Katie did it, so then it's okay. Okay. All right, so some disclosures. There's a lot of disclosures, too many to read. Obviously very biased research, so when we're talking about climate-related risk, we're getting paid to say that climate change is real, obviously. Anyway, so that, yeah, just some disclosures. Okay, so we have 3 objectives today. One, we're going to go over the literature and impacts of climate-related disasters on pediatric health specifically. Number 2, we're going to assess the impacts, right? So we're going to look at, of the wildfire disaster, right, what patients within CHLA were impacted and, you know, what that looked like. And the third step, right, and maybe arguably the most important step, is to discuss policy, right? What decisions can we make to strengthen health system preparedness for improved health outcomes and health equity? Okay, so what does the literature say, right? So on the impacts of climate-related disasters on pediatric health. Okay, first up, climate change intensifies disasters, right? I think we all know that. They're making them more frequent and severe. I think Katie mentioned this specifically for wildfire, right? So it's a trend we're seeing across, you know, across a whole multitude of different climate-related disasters, right? So specifically in California, we've got wildfire, but we've got earthquakes, you know, elsewhere regionally, you've got different things. But really, we're seeing a lot more of that, and we're seeing a lot more dangerous impacts of that. Second, right, children are uniquely vulnerable. Children are really small, right? So their immune defenses and sort of biological defenses are not fully developed, and they're not fully there. So when we're talking about fire, right, what does this look like for, you know, their ability to, for their lungs, right, and for their bodies and you know, just development overall. Compounded conditions worsen impact, right? So we talk a lot about comorbidities, and we're all here, right, because of SDOH. So we know that there are social drivers, right, and economic and environmental drivers that amplify health risks, right? So on top of, you know, suffering from a climate disaster, you've got other things that are, you know, potentially worsening your ability to persevere, right, and survive and really make it out healthy in what we think is healthy. And then lastly, we talk about equity, right? So we know that disaster, right, there's no real rhyme or reason as far as, well, maybe, you know, technically there is, but as far as where fire is striking, right, but it doesn't really, right, we can say it doesn't care about, like, who you are, but it does care about where you are, right? And we know that socially, right, where people live is kind of a marker of a lot of different, you know, again, social, economic, and environmental status. Okay, so what does the literature say about fire? So fire and children, bad, right? So fire is good sometimes, but when you combine that with children, it's not good. Lots of effects here, right? We have mental health, air quality, economic hardship, continuity of care, access to food and water, displacement. I'd love to talk about all of them, right? But we only have time to discuss this big 3, right? So let's go on to displacement. Right, so climate-related disasters like wildfire are a major driver of displacement. Think about evacuation. Think about, you know, you've got to leave the area because it's not safe for you to be there. So yeah, and that relocation can be short-term, it can be long-term, right? There's sort of this danger of not really knowing, right? So you can be in a situation where you might not return home, right? And that last point, right? Children especially vulnerable because dependence on caregivers and community. So. Again, we're a children's hospital, so our patients are kids mostly, and if you're displaced, right, you really have you're 7, right? Like you have to rely on your parents and your community. You have no say. You don't know where you're going. You don't know what's happening. So that's very scary, right? And that kind of bleeds into the mental health stuff, right? We can talk about that, but really the displacement is the sort of big physical, barrier and disruption into health. air quality, right? So, like Katie's presentation, right, that's a huge source of particulate matter pollution, right? And that smoke, right, can travel very far, right? You've got the fire that happens in one place, and that smoke can travel for miles, right? So we can talk about equity, right? We can talk about maybe these fires are happening in a certain place, but who bears the brunt of that air quality exposure? And then lastly, right, children especially vulnerable because increased risks in respiratory conditions. Again, small bodies, and they can't really handle the sort of pollutant stress on their bodies. And then the last big one, continuity of care. So disaster events, like we said, disrupt access to health care. Relocation can interrupt your access to regular treatment, right? So you can lose electricity. Maybe you have regular telehealth coverage and appointments, but now you can't really access that, right? And then, and maybe the bigger issue, right, is that CHLA doesn't know that, right? Like you've lost your ability to come into your appointment or to, see your provider, and there's nothing you can do about that. And then emergencies can lead to lost medication, right? So let's just say you're taking something and your house is burning down, right? You might forget to bring that, right? Or like in the disaster and chaos, you might lose access to the health resources that you need. Okay, so we're gonna move on to the second part of this, which is assessing the impact, right? So we're talking a lot about the literature and what the literature says about fire and climate disaster, but we took a look at specifically our patient cohort at CHLA. So a little bit first about CHLA. I work for CHLA, so I'm supposed to say it's the best children's hospital ever, so if your kids are sick, bring them there. Except I'm going to be moving to Children's Hospital Philadelphia next month, so bring them to shop instead. Okay. Yeah, it's the largest freestanding pediatric health system on the West Coast. I guess the key points here really just serves a large diverse population, right? We're thinking about the Los Angeles metropolitan area, so we're seeing a lot of kids from different economic backgrounds, different social backgrounds, different race ethnicity backgrounds. Top 10 hospital, and as far as scale and quantity, we're seeing about 24,000 surgeries and procedures annually. Okay, so patients, these are patients, and don't worry, this is HIPAA protected because it's a heat map, but really we're seeing the density of where our patients reside. So specifically, this is our LA County patient population. So we're seeing in the darker areas, first the butterfly CHLA, that's our logo. It's really fun and cute. So the sort of central area where a lot of our patients are coming from makes sense, right, as far as when we think about the distribution of the LA population. But really, this is just to say we have patients coming from all over, right? So as we can see, and we'll see it gets more important, we have a lot of patients right up sort of on the foothills of the mountains. But we've got our coastal population, right, but really just a lot of folks in and around the hospital. Okay, next up, we have the maximum extent of the evacuation zones, right? So January, we all saw the news, fire upon fire upon fire, so lots of fires. And so what we took was this data set that really showed us, all the evacuation zone at the given time, right? So throughout the month of January. And then the fire perimeters, right? So, and we'll see in this next map, this is where the danger comes in, right? We had a lot of patients actually live right, if not within an evacuation zone, if not within a fire perimeter, really close to that. And so, we can take a look at this map and take a pause, but we're really kind of just assessing the geographic spread, right, of the risk and the hazard and our patients that rely on care. Okay, this is a 3D look of it. We're gonna ignore the line that didn't render, that weird line, but that's okay. So it's kind of the same picture we saw in the previous slide, just sort of at an angled view, right? And this topology of it all, we have the fires along sort of the mountain ends. But actually one of the biggest fires, and I should have pointed it out, was the Sunset Fire. So Children's Hospital Los Angeles is on Sunset Boulevard, and so that fire was really close to home. So yeah, just taking a look at distribution there, and some markers if you're not familiar with LA area. LAX there, Hollywood, and Malibu. Okay, so let's look at the numbers, right? So almost 10,000 of our patients alone were impacted by evacuation from the Eaton fire, right? And that's not to mention all the other fires, right? So this is just to say we had a larger concentration of patients, close to those zones. But really, we have a total of, which, it was almost 3% of our patient population impacted by these fires, which doesn't sound like a lot, right? But that's thousands of kids that were, potentially displaced from their homes. So we have the Eaton, Palisades, Hearst, Sunset, Hughes, and Kenneth. So yeah, just taking a look at that bar chart and then, number of patients affected. Okay, we have a table here, right? We stratified our patient information by race, ethnicity, encounter, and insurance, right? To see if there was a significance if, you were in an evacuation zone or you weren't, right? So I'll gloss over the math part, and really it was significant, right? So there was a say as far as your race, ethnicity, as far as your encounter status, as far as your insurance, right? To predict if you were in an area of danger or if you were not, right? And this isn't even touching upon, air quality effects and whatnot, and we'll get to that soon. But this is just purely evacuation zone. So your race, ethnicity did matter, right? The type of insurance you're getting did matter. Because geographically, right, as we all know, place has a big part as far as our health outcomes. Okay, so this is the first pass, the graph. So now we're looking at air quality exposure, right? So we got air quality data for the entire month of January, and we're looking at particulate matter exposure for PM10, right? And this is measured in micrograms per meters cubed, but let's put some context in this, right? We see the big spikes, right? We can assume what that means, but we'll paint this pretty picture. So to make the numbers meaningful, right, we've kind of categorized them by EPA category. So what we're really seeing here, and I'll explain each part of this, but each single line is a patient. And each single line is colored by the maximum exposure that patient received in the month of January, right? So a lot of patients were in a zone where they experienced an unhealthy amount of PM10, right? We can talk about the health effects, right, respiratory and all that, but it's bad exposure, right? We see a big spike, and we had all those fires kind of start around the same 3-day span, so, hence the spike. Then we have the Hughes fire randomly started later in the month. We had a rainstorm, right, so that kind of explains the decline in, bad air quality, but really we got the brunt of it in the beginning, sort of middle of the month. So I think this image is really it was really shocking, I think, at first, but also kind of predictable. But yeah, we have 300,000 patients on this graph, and a lot of them were exposed to bad air quality. So we're going to isolate 3 here, right? So these are 3 random patients, patient A, patient B, patient C. So then we go to a map, right? So this is a map of the air quality during, the little thing is walking, but it's January 8th, where we had the majority of the fires sort of at their peak. And we've measured this by PM10. So we have patient A, right, living probably in the worst of the zones, right? So that they're getting, again, very unhealthy, hazardous amounts of PM10 exposure. We have patient D, right, maybe around the outskirts of the edge, right, so some moderate air quality exposure. Patient C, right, so this is just to say geographic distribution. We've got patients coming from everywhere and experiencing, different sort of exposure, but it is pretty bad for everyone. Okay, third part of this is discuss policy, right? So what do we do to strengthen health system preparedness for improved health outcomes and health equity? Okay, so this kind of goes into Malaika's graph situation down here. So what do we say, what do we think, what do we do, and what do we feel, right? So the CHLA mission, at least, is to provide safe, effective, and compassionate care for all of our patients, right? So this sort of diagram really, I think, is maybe the space we all sort of work in, right? We do the research, we want to advocate for the policy. Maybe that last part, right, health system application, is the part that I work in as far as, how do we make those decisions in the health system, right, for practical effect. But then we know that this process is iterative, right? We have findings, we have the research, we present it, we can advocate for things, but things change, right? And we want to work with our different stakeholders. So this is a model and a framework, but really just meant to be adaptable. Yeah, so as we kind of mentioned here, the data informs the policy we make, right? We encourage adaptable decision-making and iteration, and really, again, all of the space we inhabit here as far as interdisciplinary teams, right? So that's the sort of key part, right? So my boss is an anesthesiologist by practice, and so I think the key driver here, right, is that he's got the clinical knowledge, right? And, I'm bringing them to the spatial work. But that's sort of the, teamwork and sort of discussions we have to really integrate, what seems like entirely different disciplines to make meaningful action, right? So we can create a framework, right? What does policy mean? We can break that down into the clinician level, the health system level, and society level. Okay, what can your clinician do? Your doctor can't pull you out of a fire, but they can help you understand what to do in case of a fire. Maybe. So we want to understand social, economic, and environmental determinants of health, right? So That's up to the clinician to sort of really assess and understand, right? You're going through more than what your charts show, right? And that's sort of the key thing here. You want to screen for climate-related risk, right? So, I mean, the obvious one here with fire is respiratory risks. You want to provide guidance for best practices during, exacerbations of coexisting conditions, right? Like let's say I'm a clinician, I have a patient, I know that they experience worse, respiratory exacerbations during times of bad air quality, right? What do I do to prep them for that, right? And then establish flexible follow-up options, right? So in the case of emergency, right, in the case of evacuation, how would you connect with your patient in times of distress? At the health system level, right, so this is CHLA hospital level, we want to integrate social, economic, and environmental determinants of health into patient profiles to identify vulnerable populations. Again, none of this information exists on the electronic health record, right, and I think it's really valuable when we do these sort of spatial analyses or qualitative analyses to join, right, like what do those social, economic, environmental determinants of health really look like for the patient, right? We know their blood type and we know where they live, but what's the context in which they live in? We want to identify patients and staff immediately at risk to optimize scheduling. This was a big one for the wildfires, right? We had a lot of patients displaced and, lost access to care, but we also had a lot of our staff at the hospital displaced, right? So what does that mean? We have Dr. A who couldn't go in for surgery because his house just burned down, right? But that pushes back scheduling for the kids that needed care that day. So it was a mess, right, as far as scheduling. So I think really having a grasp, right, if that means integrating geographic processes into understanding who's affected by, disasters like wildfire, it really will help with optimizing, care and making sure people get the care they need when they need it. We want to communicate emergency information in multiple languages and formats, right? We talked a lot about accessibility today and yesterday throughout the conference. And so it's not enough to know the information, it's how you get the information out there. So we want to make sure that, everyone can understand the information. In LA specifically, we've got a large Spanish-speaking population, so how do we, spread this information in ways that they can understand, right? We talked about health literacy, so just ways of making it more accessible. We want to strengthen infrastructure resilience, right? I think this is sort of the thing to say, you don't want the hospital to burn down, right? So as far as CHLA specifically, luckily it didn't burn down, but I think sort of as a general rule, having, robust infrastructure. And the last one's society level. So I've sort of broken it down into 3 parts, but professional organizations, right? So my boss is actually on a board, but really it's sort of this push at the national level, right, to integrate this sort of research into, practice, right? So how do we get climate-related health risks in a formal training way for, future providers to understand? So it's really starting from the way up as far as, creating a framework for all future providers to really understand and, again, be cognizant of climate-related risks. Legislation, right, we can advocate for policy that mitigates climate risks and pushes for health equity, right? So that's a big one, right? Whether it's reaching out to your local policymakers or going above that, right? A lot of these decisions happen in ways that, you can't make as an individual, but you can sort of as a collective, we all, right, push for things that make sense. And then a big one actually is academic journals, right? Maybe we all work in spaces where we're publishing things, right, that are important, and I think after hearing everyone talk, right, everything we're doing here is very important, and I think there's one thing we have to recognize, or at least academic journals have to recognize, right, that, again, all the work we do is important, but it's up to the journals to also think that, right, like we want that work to be out there, so it's up to the academic journal to reflect priorities, right, and reflect what's important to us, because what's important to us is important to the communities we serve. Yeah, so bringing it back to our motto, right, providing safe, effective, compassionate care for all of our patients. Yeah, and that's kind of it. That's the team up there. I'm on the left. Oh, and references if anyone wants to fact check.
All right, the final grilling of the day. Questions? We got one back here.
Hi, this was really great, and the maps were so impactful, and so thank you so much for doing this work.
Thank you.
So I have 2 really quick questions. The first is, do you know, and it's okay like if you don't have the data at this point, but do you know if there was an increase in acute hospitalizations among the pediatric population at your hospital? And then I guess the second one is, at LA Children's, what's the general age structure? Is it under 18, or do you also have a large AYA population? Because I know some children's hospitals expand to AYA.
Yeah,
Or
okay.
adolescent young adults, sorry.
For the first part of the question, right, so as far as if acute hospitalizations did increase, anecdotally, I would say yes. But as far as the data, that's not something we have on hand just yet. But again, I'd like to think sort of in the chaos of things and what I've heard, quick answer, yes. Official answer, I don't know. Second part of it is specifically for this research, we sort of cut off our patient populations anyone at or below 21 years of age. But we do service populations that are above that, right? We are a tier 4 center, so a lot of specialized care comes to us, so whether you are a child or not, you can be seen at THLA, but that's just, again, patient population we can account for this specific study.
Oh, here, I was gonna say, you have to talk to Bob Food too, because he's doing his dissertation on this.
Yeah, great presentation and great work. Thanks for sharing it with us. My question is, it seems like you're using, you're wearing a couple hats, both as kind of a academic researcher and also your work at the Children's Hospital, which I think is very, unique and important. And it looks like you're also looking at some public data sources as well as some HIPAA-protected, hospital data. And I'm wondering, kind of going forward for many of us who probably are not, working at hospitals but are researchers or data people, what's the potential and kind of the avenues of kind of collaborating with, people in the hospital system, when there is, some barriers around, being in different circles and also working with different privacies with data and so on. So I wonder if you have any thoughts or lessons about that.
Yeah, I will say I acknowledge that I exist in a very niche space, right? So I feel very lucky that I have access to the EHR systems, but that's not something, right, like anyone in this room can, hit up your local hospital and ask for it. But I will say there are, as far as like official avenues, right, there are national data sets, right? There's BPS, which is ICU data cumulatively for children's hospitals across the US. So if you go to the BPS website, there's pathways to get that ICU data. But those sorts of again, combined databases do exist, and I think there are formal pathways to get in. But, I kind of got my in by knowing, this, practicing anesthesiologist who had spatial questions, right? So he gets the data, right? I'm not involved in asking for the data. And then I luckily just get it. But yes, there are databases out there where you can formally apply. And BPS is the only one that's coming to mind for some reason, but that's ICU data, or pediatric intensive care unit data.
Alicia, and then, we're going to the last question.
Hi, thank you. I was super interested in your idea of these different levels of resilience and frameworks that this applies to. I know you mentioned infrastructure resilience in more of a structural engineering sense, or at least that's how I took it.
Yeah.
I'd love to hear more about different types of potential structural resilience that you see supporting.
This is another project we're working on. So humidity actually plays a big effect in operating rooms. So there's actually an acceptable amount of humidity in an operating room for safe procedure. So that's 20 to 60%. You go below 20%, you have risk of fire. You go above 60%, you have risk of mold, right? And you can't really expose open flush to moldy instruments. So that's an infrastructure project as far as making sure a hospital infrastructure has the capability to filter air and dehumidify or humidify spaces. Actually, there was this period of time in LA where humidity got really bad, right? It was over 60%, and there were some hospitals that had to, again, because it's procedure, had to close their ORs because they can't operate safely. So infrastructure, right, sort of structural engineering, as you mentioned, but also just making sure you have systems to clean the air inside the hospital.
And I know that there's at least one more question at this table, so be sure to reach out. But with that, well, thank you so much. And we're going to be closing things with our brilliant conference organizer, Marco. Thank you so much for all that you do.
Okay, so now everyone can hear me, stop using that. Or not be so focused, right? All right, so yeah, I have the honor of closing us out for today. And it's been, like, let's see, a year and 3 months since the last symposium, which I know to y'all might seem like a lot, but for me, when I looked back at that, I was like, no, it feels longer. And I don't think I need to tell anyone in this room that this year's been a bit of a challenge. It's been a little bit rough, and it was hard not to feel like scared or angry early on this year, especially with regards to the project, social determinants of health, and health equity, and all of that good stuff, all of those words that now are becoming a little bit sensitive to talk about, which is a little upsetting to say, but I digress. And when it comes to the project, we were a little bit concerned about whether or not everything would continue as planned, whether we were going to have to delay certain things, and have all of those serious conversations of contingencies and plans and what to do. Early in February, we got tipped off for public health data sets being removed from being publicly available. And the entire lab dropped everything. All of our engineers, all of our grad students, undergraduates, research assistants that were available at the time, me, and my limited experience of downloading those data sets and working with them, all of us came together and grabbed as much of the data as we could, downloaded it, stored it, organized it. And that happened a few times over the course of February.
It started in January.
I started in late January, but a lot of things started in late January. Again, a lot has changed. And this happened a few times. We'd get a tip from someone, and then we'd drop everything, rush over, download a bunch of stuff, and even our own department, some professors dropped whatever they were doing to help our graduate research assistants download all of that data for as fast as the Wi-Fi could possibly allow us to do that. And I'm happy to say that we've downloaded and saved pretty much everything that we thought we were at risk of losing. And we weren't the only ones either. We had, let's see, just to name for you, Jessica Valenti's team, who downloaded CDC guidelines and prevention resources. The environmental justice index measures were saved by the Environmental Data and Government Initiative. And of course, there's archive.org that has saved a whole list of lists of data sets available. And then we integrated all of that into the Data Discovery app, so it's easily searchable and findable for anyone to use them. And I've seen that it has helped. I've had a PhD candidate be very grateful to us that we were able to save the social vulnerability index that they were going to use for their dissertation. So it's really been helpful. And last year when we were talking about this, not to start continuing on a very depressing sideline, so I'm trying to move us to more hopeful. Last year when we were talking about the main goal of the Social Determinants of Health in Place project, which is developing a community of practice where everyone that works with the social determinants of health and is in the realm of health equity can come together and support each other and create something better than what we could do alone. And this year, that feels a little bit more important, a lot more prudent to keep in mind and remember that, things are scary. Things are going to be rough. That's, I don't think, is, going to be stopping anytime soon, relatively. But with that said, none of us are alone. We're all on this roller coaster together, and it's a lot easier to be scared
when you're scared with other people. Because we're all in this together. And if this past year has taught us anything, it is that none of us can do this alone. And I saw that over the course of the symposium. Almost every single one of your talks ended with acknowledgments to people that have helped and collaborated and pitched in and helped to improve your projects. And I'm going to ignore all the ones that thanked the SDOH in Place project just because I don't want to be super biased and be like, hey, thank you for naming us. But you all named community or mentors, grad students, fellow postdocs that have helped you and have uplifted your projects. Named communities that you've helped and worked with to create something better than you could do by yourself. I would like to end real quick, or not real quick, but I would like to end if we're going to close out, I'm going to leave you with a welcome to the SDOH in Place project, better or more of just a community of practice, but something where we can all come together and create something better and more lasting than we can do alone. We will be here to support you and uplift your voices and be that megaphone to make sure that people that you are trying to help, that you reach them, that you get the resources to people that need them, and that we can all come together as a community and survive the train wreck that's going to be the next 4 years. So, with that said, I have a few thank yous. First off, thank you to the Robert Wood Johnson Foundation for supporting us and providing the funding for us to be here today, and also thank you to them for doubling down on their efforts to advance research and health equity. So early in January, they did not back down. They, in fact, doubled down and said that they were going to be increasing funding to all of their projects and opening up more. So thank you as well to the Discovery Partners Institute that provided us the venue for this wonderful symposium and allowed us to convene in a safe space. Thank you to all of the guests that have come here today, both in person and online. Again, really couldn't have done the symposium without you, literally. Thank you to the advisory board members of the Social Determinants of Health in Place project for, guiding us and making sure that all of our efforts are, focused and in the right direction. We really couldn't have done any of this without your feedback, so thank you, Malaika and Amina, who are here today as part of the advisory board. Thank you to the wonderful fellows, fellowship cohort this year. There's a big group of you over there, but I know you're all scattered here and there. So thank you all of you for joining us and completing the program. And going through the toolkit and helping us elevate the toolkit and make it better and more easily accessible to everyone that could possibly want to make a project. So thank you to you as well. And thank you to our wonderful staff that's been here. So thank you to Kat and Pyongyang and Rachel for helping us out with running the catering and planning and all of that good stuff, and the communications, especially thank you for communications, and Cameron. It's all the way back there, and thank you, Cameron, for being a wonderful photographer. Seriously, it's supposed to be great. And also thank you for helping out with communications and planning and putting this all together. Thank you so much to Shubham and Sarah for providing AV for us. Truly what they've been doing is witchcraft and wizardry in the corner, and I straight up could not have done that. I'm not being hyperbolic. I don't know. I don't know what they're doing over there, but I know it's and I think lastly, thank you, Marinia. I think that pretty much closes us out for the second Social Determinants of Health in Place project symposium. We will hopefully be back here next year with our third, and who knows what's going to happen. It's only going to be a year, so I doubt much will change. Thank you so much, everyone, and enjoy the rest of your time here.
Thank you.
We have funding for one more, so.
I'm excited.